This is a massive multiple fibroid uterus which we are operating, and you have the fallopian tube here. Of course, just to tell you that all of this was completely smudged, covered with adhesions by the time we reached here. So once the adhesiolysis is done, we decided that we should be going live for this. So you can see here the primary step which I am doing is basically, this is the UV fold, okay, that's the bladder. It's basically mobilization, and once I do the mobilization, then mandatorily I will go ahead and perform the rest of the surgery. But of course, as I said, primary mobilization for somebody who wants conservation of fertility. Good name, no? Instead of just calling it myomectomy. What is myomectomy? Conservation of fertility only, no? Shayad. So you of course have multiple fibroids here, and one by one, see this, slowly you will begin to notice that all of this, this is a broad ligament fibroid, by the way, all of this, no, we will knock out. Okay, fine. But before doing all of that, because we want to conserve the ovary, because we want to conserve everything, let's go and do uterine artery coagulation. See, when it is so large, one cannot be thinking so much about the usage of vasopressin, no usage of vasopressin. Basically the anatomy should come back to normal. Santoshi, just verify. Let now Santoshi verify, because somebody has already started it. Audio check. Vismay check.
Hello.
Oh, Vismay is audible. Great. Vismay.
Yeah, sir.
Happy Diwali.
Happy Diwali to you too.
Happy Diwali to all the members who are watching us. Just in case on Diwali you are watching us. So my question to Vismay is going to be very different. Structured, architectural, the way in which proper intellectual, yeah. Let's just sound. I am not one of those guys who is going to be sounding artificially intelligent, but no harm in making an effort, ne, for Vismay. So my question to you, Vismay,
yeah,
is obviously, we only end up meeting people who are neck deep into science, right?
yes,
I mean, they know, they only speak science, they only talk science, they only walk science, irrespective of what they practice.
yes,
They will speak science, correct?
yes,
The opinion is pretty opinionated when it comes to the fact. The opinion is very opinionated, Vismay, when it comes to the fact that people may want to put vasopressin.
yes,
And we are pretty sure that we don't put vasopressin, isn't it?
yes,
Of course, people want publications, so now we even have publications, isn't it? What is it that we have noticed while we do? That's the second Kalina, Santoshi. What is it that we notice, Vismay, while we do cesareans?
yeah,
For all these patients, because see, we are, because we are not those guys who have dedicated themselves only to fertility, or dedicated themselves only to laparoscopy, and they won't take any other distractions. We are poor people. We are basic common Indian gynecologist who does everything.
yeah.
Right? What have we noticed in cesareans, yaar? Anything happens to them?
No, the cesareans have been quite normal. I think we recently did one patient where we had done a previous adenomyoectomy for her,
Yeah.
and she recently delivered with us. And
Yellow neck. इस पार्ट का लो ना संतोष। हाँ, स्टार्ट करो ना। ये पार्ट का, ये आपने।
and for that patient, I believe, I think I also told it to sir that the scar was so good that it was not visible actually. if anyone would have not read the history, they would have probably said that no surgery was done. Like the
Correct.
scar was so nice, and of course uterine size and everything, the wall integrity was quite good, and it also turns out true for even myomectomies. Our myomectomies, hopefully there, I think in my 4 years of being here, I have never seen a scar rupture of a myomectomy of our patient.
Yeah. Never.
Never. And they have all gone till
in
term.
my career. So.
Yes, they have all gone till term. Only some preterms because of the fetal risk or the maternal risk, not because of the per se myomectomy.
I'm just wondering if it is not maybe so you can see the uterus has become little. Now, till the time this uterus stays white, okay, we will quickly go and remove this guy. This is round ligament, by the way. So I think that fear should go, right, Vismay?
Yeah.
I personally think this is one of those, lateral wall subserous fibroids, है ना Vismay?
Yes.
You can see that the manner in which the fibroid is, you can see that. See, I've pushed the bowel down, see, this is the subserosal plane. Can you see? Beautiful. Okay, Vismay, one more question.
Yeah.
Because it is Diwali. Question. The Gen Z, like how you are,
No.
right? Or you are what Z?
I don't know. I'm 90s born. I don't know.
You are not Gen Z?
No.
Oh, yeah, see. So you are what? You are like me?
Yeah.
I am with Z. I am not any idea. Millennium.
No, you're not millennial.
Then?
Millennials are, I think, those who are spend their childhood in 2000s,
Correct.
in the first decade.
अरे shit. 1988 वाला क्या है?
I don't know. कदाच
कदाच?
boomers. I don't know. कदाच.
कयो boomer? The only boomer we know is the Chewing
Boom, boom, boom.
Okay, no, it's my. See, my question was very serious. Okay, many a times a lot of this Gen Z comes to you and ask you, right? They don't have the guts to ask me now, but they still end up asking you that they've been working very hard. It's been 2, 3, 4 years of their practice, but then still they are unable to get the cases, the type of cases which they want to get.
Okay.
And which is what is causing them to lose some confidence, isn't it?
Yeah.
They feel that they are not getting the type of work which they deserve, sort of. Correct?
Yeah.
And quite a lot of them, these young children, are falsely enlightened, when they feel that, they have done one hysterectomy, so then they can do 500 more. Correct? What is your advice and take to them for building a practice and career is concerned? The reason why I'm asking you is you are one of those self-made guys now, You have your name in the industry. Everybody knows you for being a, well-respected figure when it comes to doing endometriosis. Ultrasounds and academics, and you've been on the national level with all the politics.
Yes.
You've been a self-made guy.
Yes.
And being a self-made guy with so much, it's like I've told this to many people
Yeah.
that it's like a 100-meter race, and in a 100-meter race you are expecting somebody to start their journey, and they call it so tough, these days, and they are starting their journey at 90 meters
Hmm.
for a 100-meter finish line. Okay, and then there are people who are starting at minus 30 meters,
Yes.
and then you are comparing, trying to compare, not comparing, but trying to compare the two people. So what's your sort of thought process on that? You must be, I'm sure. a
So
person like
if
you
I,
has
if
a
I
thought process on it.
yeah, so if I talk about myself personally, so when I came here like 4 or 5 years back, I was not doing like you always, when you start you will always get that basic things. You can't expect that, or the complicated stuff, the advanced stuff, the matlab I can't be coming here and asking you that now when I have not even put a trocar, and I can't ask you to do a very complicated like hysterectomy or a ureteric procedure right away. You will have to face, or you will have to like slowly grind for the basic work. You will get the basic work. Supposingly I was not even knowing how to do a TVS before I joined here, because I know how sisters used to tell me that you should do the scans like this, and this should be the angle when I first joined. And now at this level, so at that point of time, but I used to do all this basic fertility scans, 9 day the stimulation scans, the follicular study scans, and I used to do it a lot. Per day I used to do it. Sometimes I have done like 67,
50, yeah,
60, 70 scans a day,
yeah.
and then that the hand-eye coordination comes, and it's similar for even for laparoscopy. Like I used to remember that I think for 1 year or 1.5 year I never put a trocar here. And the first time I think Jay sir had told me that you Visma, you go inside the OT and put the trocar, and I was like, sir, how will I be able to do it? And he was like, you will be able to do it, just go there and do it. And actually I was able to do it. I just followed the steps what he did, because I used to see his surgery every night. Before sleeping I used to see Jayasa surgery every night, and I remember it every night. I used to revise the steps, how he used to put the trocar and everything. And then one fine day I was there and I put the trocar. So I think that's it. I think you should just work. I think work attracts work. The more you work, the more work you will get. If you are waiting
But then that's people want, no?
work-life balance will come once you have that grind. It will come in the advanced stages of your career.
Santosh, you are noting down, right?
You won't have work-life balance when you start. If you are wanting to find work-life balance when you're starting, it's going to be a very difficult practice for you, because according to the question, as sir said now, that I want only a specific kind of cases, that is not going to happen, I believe, in your starting career, because the patients will go to specialist for that, and you are not a specialist and you have not proven yourself to be capable of doing those cases. First you have to prove yourself. You have to do the, I think it's like sir doing gynec practice at this start. It's like obstetric is bread and butter, na? You can't tell no that I won't do any deliveries and just start doing gynec work. First you have to do the basic obs gynec work. Yeah, you can do your specialty as a something that you are doing parallelly, but yeah, but you have to stick to the bread and butter. That, and then of course when you do more and more cases and more sonographies, more and more you are giving results to the patient, and that works true for everything, for fertility, for sonographies, for advanced sonographies, for laparoscopies and everything. So you have to grind it out. I think that is the only point. There is no other alternative to work and hard work, probably. Yeah.
प्रति मशीन को ऑन कर लो संतोष.
एक नीचे चेक कर सर.
I'm just seeing everything. This is one. अरे हाँ, ये रमेश है, अनाथांश.
આ બે અહીંયા છે એક.
નહીં નહીં, આને તો કાઢી
હા, એને મોટું કરી નાખ્યું.
How practice changes, Vismay? 5 years. What has changed? I mean, you are here 4 years.
Yeah.
What has changed in 4 years?
In terms of practice.
Because I think practice is something which is very, very evolving.
Yes.
If somebody stays very rigid in life, no? That bhai main to that I'll do only this, you know? I'll not do this, suppose. Then the journey becomes tough for people.
Yeah, it becomes quite one-dimensional in a view. Yeah, super specialization is good, but I don't feel a lot of. We are already doing super specialized work. I don't think it requires more further subspecialization of a work. It's like I suppose you'll be doing fertility, and I think in the near future people will come that I will only do level 2 work. I won't do a level 1 work. I won't do IUS, and I won't do that is something. So that's it's a joke right now. But I think in the near future it may come that people might avoid doing level 1 work, and I will only do IVFs. So I think it's for me. I don't believe in that stuff. I think you should be someone who is multidimensional and more of a holistic person, because I think the patient also wants a holistic person. He does not want.
I wanted to tell everybody an open thing. See, always people wonder why we are so good at endometriosis, isn't it?
Yes.
The answer is fertility.
Yes, because
You don't
yes.
know that. See, the answer is because of fertility. Because
Yes.
our fertility understanding is
Yes, yes.
so brilliant.
The fertility will define our boundaries of the surgery.
Correct. And often people don't realize that. So you know, it's something which is. It's very tough to make somebody realize, you know.
Yeah. And until and unless they have gone through that, only those people will understand that.
Yeah. That's why, you know, I often wonder when you know people who do such
Yes.
less work, they speak so much, na?
Yes.
It actually now myself and Vismay, we laugh about all that.
Yeah, we get,
Yeah.
and it is for example, we are getting so many patients who are being referred to us for microwave ablation for adenomyosis, for fertility basically, and post that the patients, yeah, they are pregnant, but there are also been cases, as you know,
Yes.
that they have not been they have not even undergone transfer yet,
Oh yeah.
because the primary surgeon still believes that the adenomyosis has not been cured, and when it was already told that it cannot be cured in any way, it will just reduce, and it will be it's optimal reduction is the goal here.
Correct.
It can't magically disappear, but they are still waiting for that magical disappearance, and so I
We have had so many of the patients.
yeah, they have shift to us. Yeah, they have literally.
do it.
Recently we had one patient, like she's waiting for a transfer since 2 years.
Yeah, I know.
Since 2 years, and she was actually fed up that, and she is pain free, by the way. That patient, no pain. So that is the thing. The people are not even aware of how a uterus will look post microwave ablation.
This is number 5.
Yeah, and that leads to a lot of misunderstandings.
See, once you have done uterine artery, look at the blood loss. See?
It's nothing. Suction.
Thing, no? અહીંયા છે કઈ? Right. See, we will probably try and suture it off also very fast. subserosal actually. Seven. If the I think અહીંયા કઈ છે
ના
posterior માં 8 આવશે હા eight. So we have recorded total 8. I'm palpating and seeing if there is something else also. I don't think so, right? Vismay?
સોનોગ્રાફી કરવી છે
Sonography. Let Vismay do. ત્યાં સુધી મને 30 સેન્ટીમીટર છે Oh, beautiful. કંઈ જ નથી મસ્ત
આયચો તો હા
posterior wall. Oh, there is one more. Wait.
હું સાઈડમાં જાઉં હા ત્યાં કંઈક ટચ કર્યું ને તમે હા
ક્યાં હતું
રાઈટ સાઈડ છે થોડું
સાઈડમાં છે ઓકે there is wait પકડ see good advantage of doing a mapping
હવે પાછું એક મિનિટ તમે કદાચ એને પકડ્યું નથી ને
નહીં
એક આ પણ છે જો
ક્યાં છે
એની અલગ છે બટ છોડો તો એને નહીં આઈ થિંક એ જે ખોલેલું છે એ જ બતાવે છે કદાચ
અચ્છા
નહીં સોરી નથી ત્યાં નથી
જસ્ટ અ બ્લડ ક્લોટ ચાલશે ચાલો પહેલાં 30 દઈ દે પછી જોઈએ જો અહીંયા કંઈ લાગે તો અહીંયા કંઈ છે નહીં લાગે છે
ના ના ત્યાં તો કંઈ નથી
ચાલશે ચાલો દેવા just coming in with a 30 centimeter we had two big ones, both of whom were subserosal. So here we go. You know, these types of fibroids, I know, and I think it is challenging otherwise to knock them out, but you know, this is one of those situations where actually we will be wanting to try to attempt to do a vaginal colpotomy to remove all of this for her. exposure. It's gone pretty low down, that's okay. See. And okay, scissors please. Thank you. So one incision done. I mean, one closure is super fast. I'll use the same. I'll use the same to close the upper one as well. मन लागतो નથી આ વિષય ક્યાં છે કઈ બીજું
જોઈ લે શું બંધ કરે
પેપર સ્કેન કરીને જોઈ લે मुझे लग नहीं रहा है अभी I don't feel that there is any other one तो भी एक बारी this is तो the same incision यहाँ पे तो 15 हो जाएगा
पहले बंद कर ले
यहाँ पे just see just one incision we have closed so just let's come inside and see नहीं यार beautiful lining but पाछड़ काई नहीं नहीं so we are doing the mapping again नहीं ना चल छोड़ दे okay done come So you can convert you can convert a cut stratafix into a usable stratafix. See this by taking a loop. So what's going to happen, see this, that loop will stay stuck there. Can you see? But use it only for small wounds like this and go deep, and when you pull, see this, see when you pull na, pull it more on one side, trust me, and then anapakadak. See, Visma is holding on and we are pulling. Otherwise, what will happen? This will also go inside. Huh? So just remember that. Simple physics actually. Nothing rocket science. And here we go. One more. And I'll close it one more. पीछे से ज़रा एक बारी क्लीन कर लो, कैमरा को नहीं, पीओडी को क्लीन कर लो. So see, 130 centimeter person has worked for the entire posterior wall, right? There we go. I use 115 now, 15. So the uterus has become a normal size uterus. And I'm coming inside with a 15 centimeter. Oh, so this again, this little blood tinged peritoneum, we are going to separate off very fast. Just hold on. See this, nothing doing here. This is the outer layer of that region. So stitch number 1, you have to crumple this, huh? And I am not going to cut off all of this, you are already aware. I do not cut off redundant serosa, nothing. It allows Just keep it there. It will get remodeled. You need not cut it off. A lot of crumpled up, huh? There, see, lot of redundant tissue that got crumpled up. That's exactly what we want. Let Vismoy just suction off that. There is the round ligament. See, all this tissue, if you see, is simply serosal bites. Here we go. So, see this? The entire line has got crumpled and it is still serosa. Nothing is going to happen to it. It's going to stay beautiful. Serosal bite, serosal bite, serosal bite. Serosal bites. Here we go. So, anterior wall has been done. Cut. Okay. Suction कर लो पीछे से. Let the camera get clean now. Probably try to get ready for a vertical colpotomy. When we do this in a vertical colpotomy, we first separate the rectum from behind. Suction दे दो मेरे हाथ में. And all the fibroids, we'll try and remove them intact. Vismay, how does it help? We have done it now in fact, to all our friends, we are publishing this, isn't it?
Yeah.
So we have a huge series which we are publishing now for vertical colpotomies. So Vismay, just wanted to know your viewpoints, because then people will be like, "Arey, traditional morcellation is there. You put the morsel bag and remove."
No, sir. I think it subtracts a lot of surgical time, because a lot of patients are like, oh, the surgery took just 20 minutes, but they don't understand another 20-25 minutes is just for the morcellation. So that adds to the anesthesia time, surgical time. So if feasible, if the patient is allowing, I think colpotomy is a much better way of removing any large specimen, probably. Yeah.
So let Vismay hold the uterus up. Give me the sharer. That's a great hold. See, this is what you got to learn. This hold was never there with Vismay in the initial few years of practice, isn't it?
Yes.
नहीं, मैं बोलूँगा तब. Good one, Rasik, but मैं बोलूँगा तब, है ना? Just first incision is this. Allow the bowel to go. Vismay, how important is this incision in this procedure?
If we are doing the smiley colpotomy or even a vertical colpotomy, we are going downwards in the posterior wall. So you have to separate this denominus fascia.
Right.
Otherwise,
till where to separate? People have asked this question million times. Where? कहाँ तक जाऊँ?
I think at the level till in posterior wall, from speaking in that terms, I think from the starting of mid vagina.
Yeah.
I think upper limit of. So yeah, 2-3 centimeters probably, but the rectum separation should be always more than the cut, I believe.
Yeah.
Because there is always the chance of tearing more. So when you have rectum free, I think that mentally you are quite, and of course the fistula rates are very low in such
Very
cases.
low. Done?
Yes.
Some bleeder.
Hmm.
एक wall में.
ये तो बोलो ना तरफ
Ureter is here, huh, guys? This is ureter number 1, this is ureter number 2. See? See? Far off. I'm not even going to open them. No requirement. Nahi, Vismay?
No.
I've never found a requirement to open that.
no.
अंदर push कर बेटा. Okay. Now, the first thing which you should do is make sure that this is a big cut, isn't it? This cut. See, this is, I'm extending it laterally. There. I'm not just making a tichukda, what is it called? Tiny.
Incision.
Thank you. Now, automatically, see what has happened. Can you see that? Huge separation. That is cervix. But a huge separation has occurred. Now, see, one side I have started to go down. But the beauty of whenever I am trying to go down now is I am going down in this plane. Can you see here? When I am going down in this plane, there is any which ways no ureter, no major blood vessel. This is your smiley colpotomies. See this. Can you see that? Can you see that vessel? See? Chota sa, that is vaginal vessel. That tiny one. Tiny it was, very tiny. I immediately, in fact, before it even showed that it is vaginal vessel, I coagulated it. Now see this. See this space. Can you see? So now, basically, can you see vagina is coming out like a tongue. Now, I can customize this incision based on how much I want to go down. Okay? So, first I have done one good thing. I have created a large colpotomy. एलिस दे दो, मेरे हाथ में एलिस दो. Now this is very nice, huh?
हाँ मैंने एक सर तो मैं एलिस ले लो.
तारा हाथ में सोच.
वो खाली नेट होल्डर ऊपर करवा माटे.
ऊपर ले ले. Right. First fibroid, number 1, out. Now just start seeing, huh? Diju. Everything will start coming out intact. Of course, we may require to do certain pulling push in somewhere. Oh, this is a hard stone. पत्थर है ये fibroid. आजा. See? Third.
एक नानो છે એક નાનો.
Tiny. Fourth. આ એક છે, આ પણ એક છે, નહીં? इतना है टोटल संतोषी. See, now this will start rotating there, but I can use a simple Alice. I mean, I can use a क्या बोलते हैं, bulldog, and it will just pop out. But I'm trying to push it actually. No, it is not getting pushed. No problem. From a basic retraction modality, I've just pulled out. Huge one it was. This much तो morcellation में तो it can't come only. I mean this speed. Now कितना आया? 5 आया? Okay. क्या आया नंबर 6? देख ले. आया? Okay. अभी संतोषी बोल रहा है 3 और है. So this has to be 1. इधर आ. This has to be 2. ये एक आ गया संतोषी. ठीक है देखते हैं बाद में है ना. The other large one coming out. See everything, because we are showing it to you live, you would have begun to understand. Okay, out. See this. And now comes the final. Camera साफ कर. Now I have 2-3 options here. Okay. I have an option where I can cut it here. बराबर है विस्मय? If required, no morcellation, nothing. I can simply use a blade and I can separate. Correct? That is option number 1. It's a very soft one. To be honest with all of you. So I want to see. It's a very soft one. I do not know if I can pull it out. I just don't want to.
हाँ.
Let me see if my scissor is valid. No, scissor will break. नहीं, scissor टूट जाएगा इसमें. See, I try to cut it off, chop it off with the scissor. I am worried that the scissor will break. My staff is saying let it break because it's a disposable scissor. So one scissor, one case. It's okay. चलता है. See. Now, one thing we have achieved is that see this. If I am able to cut it off into 2 pieces, the total time, as I told you, some parts of the fibroid are pretty soft. So the total time which I will require, see, when I am cutting, it is very soft on some parts. Even if I am able to chop it off into 2 halves, nahin? For this entire lesion, then also it will come out very mast. I'll tell you one thing, guys. If it is a very large fibroid, larger than this, then instead of using a 5 mm scissor, which I am using, please use a 10 mm blade and just cut it. Okay? We do not have a 5 mm blade. There is no such thing which is available. I know people can also say that I just put it in the vagina and then vagina may say only just extract it. Correct, correct. That is also same. See here. I don't know if this much is enough. Nahin, Vismal? I don't know. I don't think so. I may, yeah, I can little wobble it from down and then maybe. पकड़ी रखते. See here. आ जाओ यहाँ कट कर. This maybe it's okay now. Sula. Let's see if we can try and smooth it out. Because we have sort of cut it into pieces, na. Chota chota we have done already. It is nicely gone in the pelvis also.
एक मिनट.
Hold the uterus. Just want to be sure that I'm only holding the fibroid. Yeah, it is only the fibroid. Chalo. It's stuck. See this? It's okay. I'll try and take it out from down only. नहीं कर.
Okay.
छोड़. Gas off कर. So guys, once I remove it, okay. In the meanwhile that I am removing this, once I remove it, I'll just close off the colpotomy. So thank you so much for watching us. I'll just remove it from the vagina. Thank you guys. Bye bye. Happy Diwali. Take care.